Great. So welcome everybody to this conversation with Kate White, who I'm sure you all know has been in this field for a long, long time and is very well respected. And today we're going to be talking about baby therapy in the real world. And what that really means is like beyond the kind of theoretical, what are the kind of issues that come up in practice on a daily basis that we need to address as therapists? And of course, it's really great to have your questions as we go along, and we'll cover those as well. So welcome, Kate.
Well, thank you, John. It's always nice to be here.
That's lovely. Great. And I know you've got a huge amount of experience with this. So let's start with the question around how do you explain what you do to someone who inquires, particularly when someone might be a bit skeptical? Do you have sort of like key phrases that you use to someone because, a lot of the time when we talk to people, well, certainly when I talk to English people, they have really no idea what I do. And so,
Really?
what do we say to people who are just inquiring and they really don't know much about this work at all?
Um, well, usually the first inquiry is like they call me up and they say, well, I've heard about you. I've been referred to you um, for work with my baby. Often it's the parent that calls up and just says, I have a 4-week-old, an 8-week-old, sometimes 4 months, even older. I work with children, older children as well. But I've been referred to you for birth, so issues with the birth or issues with feeding. Um, can you tell me a little bit more about what you do?
Mm,
So I just explain about the baby's body. I explain how the baby has experiences, how in my clinical experience, that if there are things lingering after the birth, that it's likely from an intrauterine constraint. And there's fascia and muscles and experiences in the tissues. And so I use my hands, a variety of techniques with my hands to help relax the baby, open the baby's body if it's constricted, and that just to help with feeding. And I usually will ask their intention, like what, and it's often feeding that brings parents in, but sometimes
mm,
it's sleeping and crying. Those are the top
mm.
three. So
Yes, they're
do
very practical things, aren't they, that people want help with
yes,
usually.
it's very practical and it's not very esoteric discussion on the
Hmm.
phone, but when they get in and I'm doing the work and I'm sitting there, it looks like I'm doing nothing. So I'll say, I bet you this looks pretty mysterious, huh? Do you want to know more about what I'm doing?
Uh-huh.
And so I do explain that I'm listening to the baby's body, that babies are very potent, that there doesn't take a lot to help a baby, at least in my opinion, in my clinical experience. And I'd like to teach them a little bit about how to work with their baby as well. There's a whole intake, a long intake of inquiry questions. What was the pregnancy like?
Mm,
Was conception easy? What was the birth like? What was after birth?
mm.
I explained about the layers of experience, how they can show up in the tissue and in the baby's experience. I listen to their experience. Often, if I work with them, the baby gets better. I explain it's a whole, group of things that I am tracking. Um, but I get right to it when they come in. If they have, it's usually something pretty intense, and I go right to helping them as much as possible.
Yeah.
Uh, and then it
Yeah.
unfolds from there.
Yeah. I mean, I suppose one of the key things that we need to find out really is their expectations, isn't it, about what they really, really want from this, first of all, right?
Yeah, what do they really want? And I have, the skull, the infant skull,
Yeah.
and I'm able to show them the foramen on the underside of the skull and to say, here are the openings that have cranial nerves in them. I have my poster series. I'm able to explain cranial nerves and the
Mm,
baby's body. I'm able to explain, reflux and baby's posture and baby's that are trying to tell their story, and um, it's and I kind of decode what the baby's saying for the parent, and then I bring the parent in. Sometimes the baby and I are having a conversation, and the parents are like, "What are you doing? What is that?"
Yeah.
And I'll bring them in to have them tell them how they can do this too in their own way. So,
Mm. And what do you, I mean, if you find that, as is often the case, like the mother or the dad or whoever's there really needs more help than perhaps the baby, how do you language that with them to say,
that's-
actually, perhaps there's something going on, something happened in your pregnancy that perhaps needs some help. You and
how do
Yeah,
I
is that
language
that
it?
it's actually perhaps more to do with the parents than it is to do with the baby themselves.
When it's more to do with the parents than the baby.
Yes, yes,
Well, I usually will listen to them, the parents first, and they'll say they're like, I'll tell you a brief story to give you an illustration. But before
yeah.
I do that, I wanted to see, Anne, I saw your hand raised. Did you want to say something, Anne? I saw your hand go like this. Yeah?
I mean, it can wait, but I'm curious for you to elaborate and say what you mean. But you say you go right into helping them. I'm not sure what that means. So at some
Um,
point, you
well,
can.
okay. So as a PPM practitioner, I'm tracking a lot of things. And of course, you hear what's happened. Usually there'll be a phone conversation, and I'll say, "Well, what brings you to call me?" And I'll listen. And usually on the phone, I start to explain, um, okay, it sounds like your baby, has some constriction. Usually it's feeding that brings them to me. And often it can be a tongue tie or a fascial constraint or pain at breastfeeding or in my baby doesn't like me to hold him or her or them. What is this? And I'll elaborate on the baby's experience. And then when they come in, I go right to the complaint. Like, it's painful at breastfeeding. And I'm like, okay, well, let me listen with my hands. Often I can feel in the cranial bones and the tongue and the baby's body the constriction. And so I'll explain it all. And I have my posters and I have the whole cranium to show them. And so I go right to helping the complaint. Now, sometimes it's much bigger than the complaint. There's other things that are going on. Does that help, Anne? So the story I was going to tell was like once upon a time, I had a family bring their second baby to me. And this baby was a breech, had been born breech. So I recognize the baby's, posture because I know about breech. I'm a breech human as well. So, so I listened to their complaint. The baby's crying. Will you please address the crying? So I looked at the baby. He was throwing up a little, babies spit up. But I put my hands on him and I listened to him. And I said, your baby's pretty good. Like, what's going on with you? Tell me about you. Tell me about what is bringing you here. And they explained that they had a first baby. And that baby cried and cried and cried. And I said, I think you have some PTS from the first baby. So this baby is actually pretty normal. But let me talk with you. Let me listen to you. Let me help you. Because they gave me the baby. He was all of 4 weeks old. And they said, fix the baby. And there was a lot of fear. Now, if any of you have been with a baby that doesn't settle, that cries and cries and cries, it is a form of like torture. And no, the family was filled with dread. And so this is a previous trauma. And so I treated them using like somatic experiencing type skills, like what happens for you. Tell me, I had to go through the first baby. And while I did that, the other baby was there quietly listening, not crying, not even being agitated. This baby was pretty good, actually. So I think what practitioners need to know is like how to read what the baby is saying and autonomic nervous system responses, tissue responses, gestures, the body postures, all the symptoms of vagus dysregulation, especially spitting up refluxes when it's not normal. Babies spit up, they hiccup, and some babies feed differently. And so I try to help the parents understand their babies from the inside out. Because I think one of the mistakes we make culturally is we think we know babies. We think we know them because they're a baby and it's the outside in. What do we do with the baby? What do we buy for the baby? What baby, if you listen to the babies are all different. And so really getting that there's a human telling their story, their unique story. And their babies are not like other humans. They're not like children or like adults. And so it just has taken me many years of being with babies and families to really have the experience that I do. It's taken time. Yeah.
How do you, I mean, in that kind of situation, Kate, I suppose it'd be quite easy for a mum to feel guilt, which is a very, very common, unfortunately,
Oh
thing
yeah.
to feel, rather than saying, well, it's all your fault. It's like, no,
I know.
yes, no.
Well, that's not what I said.
No, obviously you're not going to say that. How do you
No,
language it? What do you say to sort of assuage guilt? Because it's such a common, I was going to call it emotion. I'm not even sure it's an emotion really, but it's a common thing.
well, I think that parents, no matter what age their child is, are first to blame themselves. We all
Yeah.
do. We all blame
Yeah, we all do.
ourselves.
Yeah. Yeah.
So I say that. I mean, I have children too. There are things I feel responsible for. I didn't see it in my own life. Um, and I try to listen to them. Mostly what I think wins them over is the compassion
Mm,
that I have for them. And for this particular couple, I could feel how scared they were because I think they had completely been overwhelmed by the crying of the first baby.
mm,
And I was able to feel like this must be so hard for you. Tell me more. Tell me everything. And that it's that kind of care that I think that parents respond to. And parents are first to blame themselves. So I often will back up and start with what happened. Tell me about the story. Tell me about what happened here. And usually I can find a foothold somewhere to help alleviate their concern and also to help them feel better about themselves and about what happened and help them understand their baby.
yeah.
But it's taken me 30 years, John. I don't want it to take that long for the future of our practitioners.
No, exactly, exactly. So I think you got some other case studies as well, Kate, you wanted to
Well,
go into
I have
detail,
quite a
yeah?
bit,
Cool.
actually, I can tell people, but I'm wondering if there's any questions that people want to hear. Like I have some pivotal cases that helped me understand babies better. Um,
Yeah.
but but I'm wondering if those of you who are listening, and then I see people I know, I see Yap and Violetta and Nina with her baby. I see your baby, Nina.
Mhm.
Um, and if you have things that you want me to address, put them in the chat.
So Catherine's
Uh,
written a couple of things there. She says, I tell parents, caregivers that it's a bit like watching paint dry, which is good.
yeah,
But the
that's
whole
good.
room will experience the cranial touch by being in the field with us. And she's
Uh,
also asking, which is a big question, what does a breech baby express? I think that's a very interesting question. But do you want to say anything about that?
About breech babies? I
Well,
mean,
she's particularly what does a breech baby express? So in their like in their
well, it's
body
the thing.
language or whatever it is.
Well, every baby is different. See, here again is the part where I get like, all right, I can talk in general about breech babies, but what is the breech baby that you're bringing that may have their story? And this is one of the things I really object to. It's like I can tell you with the categories of babies' experiences. I try to teach that in the training programs that I offer, but I also teach like really exquisite listening skills. And um, for a breech baby, they don't know any different than their own experience, and they're not any different than the experiences of other babies. But they may have had a very challenging birth. If they were born vaginally, breech births are very painful often. They're scary. People are scared. And there's depends on who the practitioner is. Um, but so often practitioners tend to get scared around breech babies because they can very easily have their cord impinged, their body comes out before their head. There can be, cord impingement, and then the baby can have hypoxia or even die. Now, a lot of breech babies, we lose consciousness because we do get hypoxic. And a breech baby is a neurodevelopmental marker. It's one of those I've learned from reading the research that breech may have an extra special, stress marker because of the quality of that, that presentation. But it depends. So I've met breech babies born at home. I've met breech babies born in hospital. I've met babies that have had their first baby, the multiples, the baby that are born. First baby comes head down, and then the way is so much more open. And I've met babies born breech with the frank breech, which I really admire that. That's a nice wide opening that's come if the cervix doesn't close too quickly. And I mean, I just think it's scary for providers who are not trained, and the parent can get scared also. And there can be things done to the baby like grabbing or not allowing the baby to do their thing. Because babies have things sorted, believe it or not. I believe they do. And if you interfere with them too much, then they can get more stuck, or they can have impacts from your interventions. And sometimes you've got to intervene because the baby needs help. And that's the art of being a birth provider. So babies' heads are breech baby were foot long heads. Like sometimes when I teach my classes, I'm like, you want to put your hand up here and feel my head. Like people are, when I was in bodywork school, they would say, "What's that?" They put their hands on my head. I'm like, dude, that's my head. And it's like breech heads are different, and that's okay. So but I think that sometimes the breech presentation is just very stressful. But I've met plenty of head down babies that are very, very stressed, and babies born with C-section, very, very stressed. So yeah, I think I'll stop there.
No, I'm really glad you answered it. That's okay, because it's sometimes easy to overgeneralize in this kind of situation, or you have an idea when the mum's telling the story that, oh, that baby was breech or it was C-section or whatever it was, and you get certain ideas in your mind about what might have been going on. But as you say, it's very, very different from baby to baby. You can't really say that. So, but there is a question here from Barb about the baby's experience when they present as breech and are turned in utero. In fact, I was talking to a mum about this this morning actually, and her experience of how painful that was.
Yeah,
they tried to turn her 3 times and it didn't work, and she remembered that very well. So yeah,
she was the adult remembering her own
yeah,
birth.
yeah, yeah,
Yeah, that must have been awful. And um I don't know, the breech being turned, I mean, sometimes I can talk babies into the head down position and explain to them the benefits of being, if they're going to be born. Like it is I experienced my birth as very painful. But I mean, not every breech is going to say that. And like I said, I've met head down babies that they've just been really hurt. Because that's my job, is to work with really hurt babies. But the version is the forced. But if you can talk to the baby and tell the baby what you're doing, then sometimes baby is in cooperation. But there's so many variables that can go into why a baby is breech. Um, but I know people who have had successful versions and been very glad, it's what I call a version, to turn the baby, and very glad to have a vaginal birth that was straightforward and not a breech, scary birth.
Mm.
Um,
Yeah, and of course, I mean, it wasn't so long ago that breech births were born quite often vaginally. I mean, one of my colleagues, actually, Jane Evans, she used to teach with Gail Tully all over the world around how to birth breech babies vaginally. So it's more recently, isn't it, that it's come in that most now are not born that way. They're born through C-section.
that's right. They
So,
forgot.
yeah. Yeah.
So I mean, I would really like to write my own little book about breech. It's called Head Up in a Head Down World. And I don't want us to talk all about breech here because there's
There's a lot of questions
there's
about
only 3 or 4% of us in the world that are born that way.
it.
And we're fairly unique individuals born for breech. And I have my categories of like ideas about who we really, what happens to this particular dynamic if we choose the breech. And there's been things that have been told to me, there have been thoughts about it, but my own inside out experience is, I had gotten stuck and I had it figured out, but it really did heavily impact me. And it's taken me all these years to sort out my own
Right.
my own experience, right?
Beverly's saying, yes, please do write a book about breech. And there's one last question, if you don't mind, from Beverly about the breech experience of fundal pressure. Can you just say anything about that? And then we'll leave the breech subject.
Well, that's a pretty big deal. Like if you have twins and one baby's head is right up against the top of the fundus, they get very compressed. Or fundal pressure that comes down, while you're being born. But I used my whole body to be born. It's not just my head. And I use my arms, and there was a lot that I had sorted out before I was born. Um, so yeah, I don't know. Baby's fundal pressure can be like a lot of compression on the neck, and the head can be tight. But I've met plenty of head down babies who have the same. So I wouldn't want to put this category in a special category, except for if that breech baby presents in a certain way. And then it's like, I don't know if you all know the man, Jonathan Evans. He teaches this baby courses online from Australia. He has these brilliant maps. And so you're like, if this, then this. I mean, he has created all these maps, and that would be what I would recommend to baby body workers listening. If this, then this, then this, then this. I mean, it's a form of inquiry and observation. And also, like, I use my own body. My body gives me information. If you're a body worker, your body does that. That's one of the things they did not tell me in bodywork school. Is that your body gets really sensitive and figures stuff out and tries to communicate it to you. And so you pay attention to yourself while you're working. And if you are working with babies is an advanced skill. And so hopefully you've done a lot of other things before you've gotten to work with babies.
Anne's just asking about the name of Jonathan Evans, you said, right?
Jonathan Evans, his website is Kindred
Website,
Bee.
yeah.
And he taught in my online school.
Couldn't
for a while, and I just he has several courses on working with babies, and his maps are really good.
Hmm.
Yeah.
So Helen's asking a different question now about how you work with babies who are constipated. Do you have any
Yes, I
particular
mean,
kind of
I can
approaches with
talk
that?
about
Yeah.
that.
Yeah.
Well, besides teaching just, helping with poop, which is, how to do the I love you stroke, and teaching the parents how to do that. I have found that releasing the psoas muscle can create, um, release of bowel movements, really. That's I use Bowen for that, John, which I'm sure you do
Oh.
also. I release the low back and I release the psoas, and the baby has a bowel movement. I also work with all the diaphragms to make sure that things are not clamped down. But again, this is a question about, okay, what is your baby eating? And if there is also, vagus nerve issues, or the baby is uh, had a big scare, or the baby came out too fast because everything's clumps, especially the cranium just gets real tight. And so you have to just do your inquiry, like how's breastfeeding going? Or if you're not breastfeeding, tell me about the formula feeding. And there could be something that they're eating that's creating it. So, I mean, again, it's a lot of different things when you have a
Hmm.
baby that's constipated, and then people have different ideas about what is constipation. My baby hasn't had a poop in 3 days. Some babies, that's normal. But no poop in 7 days, that's not normal. That's not normal. But it depends on who you talk to, like, and what they're eating, and how is the life at home, but how is the baby's body in general. And I release the whole body. And I don't know how many of you out there are baby body workers, but I highly recommend the Bowen therapy. That's been the best. I love the cranial work. And I love all the things I've learned pre-perinatal, but the Bowen therapy, I can help a baby with just a little bit, little tiny movements of my hands, and
Hmm.
then the baby can breastfeed or relax. And so I highly recommend that. And I can give you a case study that changed my whole practice. Um, if you would like me to start in on my case studies, John.
Yeah, that'd be lovely. I could just say a little bit about the psoas as well, okay, because it's something I use a lot with babies, and it's really interesting. I think the psoas, well, I think everybody knows that it's like attached to the back of the diaphragm. It goes massages all the internal organs. So it's very involved with sluggish digestion and things like that if it's tight. And I think with babies that can get quite activated even in the womb, probably, but certainly certain kinds of birth. I think particularly, like cesareans or anything that applies traction on the neck, like suction or forceps or C-section, that because you have this instinctive, we all have that instinctive thing to kind of protect here. And as soon as we do that and we contract the suboccipital muscles, the psoas starts to contract as well. They just go together like that. So you
Mhm.
can, you see a lot of babies with those kind of things. It's typical colic kind of pose, isn't it, that?
Mhm.
And so I've found, yeah, I mean, the psoas work, in the Bowen work that I do is so gentle, and
Yes.
quite often I'll access that just like on the lesser trochanter, just lateral to the pubic bone, and as long as you explain, what to the parent why you're doing that, it has this pretty magical effect, and you can see it like right through the body, and also with their neck as well, like, oh my God, everything just opens out. It's really beautiful. And as you say,
It's true.
it's so easy. I mean, it's so light and gentle. It's like you're hardly touching, and it's great. And yeah, cool. So do you want to go into that case study, Kate? Yeah. Is that all?
Yeah, well,
Yeah.
there was one baby that taught me so much, and her name was Alice. And I know I've talked about her before with your programs, John.
Yeah. Yeah.
Alice was for, I think, 6 weeks when her mother brought her to me, maybe 4 weeks. Anyway, she was a really, really big baby because her mother had a lot of great letdown, but she had such trouble breastfeeding and a lot of spitting up, huge amounts, and a lot of unsettled, very unsettled. And her mother actually was in postpartum depression also. Like I could tell she was very diminished. And so the first time her mother came to me, her body had a lot of constriction, and her head was the shape of a trapezoid, so it had a lot of constraint. And so, like I said, a lot of times if things show up in after birth, they're usually an intrauterine issue. There's something intrauterine there, and so in my inquiry with her, like she had gotten stuck posterior at 22 weeks. So she grew her body in this sort of C shape with her head posterior. And she did try to get herself out. Her mom said she kicked and kicked and kicked, but she couldn't get out of that position. And she had an anterior placenta, which is another thing I've learned to ask about. Where was your placenta? Because the anterior placenta will often trap a baby behind it. And then they're stuck in their body and they can't move. So she grew her body for 28 weeks in that posture, and there was a lot of fascial and muscular constraint. And so I started treating her before I learned the Bowen. Um, and she had such difficulty because you can imagine her jaw was way to one side and her head was really oddly formed and her body was oddly formed. And this is a baby that when I would hold her, she would throw herself upside down. She loved extension. And so I never used to like really hold babies that way. And then this is the baby I learned if I grabbed the fascia and started to pull with my fingers on her body, she would settle. Otherwise, she was constantly trying to find comfort. She loved the fascial work. She was big. And so I have documented in a case study how her body eased over time. And after the first time I saw her, I went and learned the Bowen work from Judy Terwilliger, John. And I came back and with one little flick of my finger, I released the suprahyoid muscle. And suddenly the baby could eat without discomfort. And the mother's, postpartum depression lifted. And this baby needed a lot of body work, so not the normal. So I waived my fee and I just treated her body until she really evened out. And I don't know how many it took, but she made improvements every time I saw her, and her body normalized, and her tummy time was really important. And I gave her mom things to do with the baby's body. And now the baby is in third or fourth grade, I think, and you cannot tell. You cannot tell she was so misshapen um, because of the body work. But that baby taught me a lot. Um, I'm very
Mm.
grateful to Alice and her mother, and it was a baby that taught me the importance of releasing fascia, because we tend to think of babies as these little gentle, breakable things, when actually some of them have a need for what I would call functional work, not just the biodynamic work where the bones are all floating and easy and you can move them. This baby had fascial constraint that was so intense, and the folds that had been made in her body from the way she was in utero and how those eased, but it was fascial work that helped this baby. And then the cranial work, and then the attention to the parent, listening to her. I mean, she was desperate when she came to me. And a lot of parents are like those back in those days. Now, I have just moved away from Charlottesville, where I lived for 17 years, and at the end of my stay there, I was I was one of the first, like, if you have a baby that's having challenges, go see Kate. But when I first started there, it was like, oh yeah, that cranial sacral therapist. I was the last one in the line that people came to see. And now I feel like people are knowing more about body work and body work for babies, and it's come through lactation, and they will recommend body work before the tongue tie releases and things like that. But that baby taught me a lot, and I was very grateful to learn
Mm.
from Alice.
No, that's fascinating. I gave a talk at the British Fascia Symposium many years ago about the effect of different kinds of birth on baby's fascial network. And it was really interesting because it was clear that they hadn't thought about it before. And it's like one of the primary fascial imprintings that we get as we're born. And I also find it very interesting, like, that the way our babies' bodies are designed for this, huge forces, aren't they? Like, but they're mostly to do with compression and dragging forces and all those kind of things, but
Yes.
mostly compression. And I find it very interesting what happens with the fascia, particularly when you apply other kinds of forces which perhaps the body's not designed for. So it's not designed for these kind of pulling forces, these tractional forces that are really extreme sometimes. And you get
Mhm.
all kinds of patterns set up within the body, like you were just describing them in those situations that go all the way through, the dural tube and the whole fascial network. And apart from the fact that a lot of those births are quite painful and stuff. So I
Yes.
suppose my question, I know we've talked about this before, Kate, is like, I think a lot of pre and perinatal workers are perhaps reluctant to, I was going to say intervene, or like when you see something, well, actually that needs, say, a bit of hands-on help. It needs perhaps releasing, like you've just described. Can you talk a little bit about that?
They're reluctant to
Well, just
release the
like
baby.
when we see that perhaps the baby needs a little bit more help than just listening, right?
Oh yeah.
Because a lot of
Um,
what we do is listening, isn't it? And babies show
yes.
stuff and they go through processes and all this kind of stuff. So when do we need to perhaps do a little bit more than that?
Okay. Well, the stuck postures, as you know, John.
Mm,
Um, I learned a lot from, like, I take classes from people all over the world now. I mean, from osteopaths and other cranial people. But, you want to look at their anatomy and assess. Assessment skills are like the very first skills that you need to garner when you're working with babies. And how are they left to right, front to back? How is their eye contact? And then like the hardest positions besides the hardest positions that I have seen have been what we call fixed lateral flexion,
mhm,
retroflexion, which is the head turn and the
mhm,
shoulder up, and you know
mhm.
I mean, I feel pretty lucky that I got trained to work with the pediatric Bowen work, because then it's easy to see the constraint and how it
Yeah,
goes through the body.
yeah.
So I will explain to the parents that this is fascial constraint. This is also their experience in utero. And I ask questions. Do they sleep in this posture? Are they mouth breathers? How is breastfeeding? Because breastfeeding will show up. Even regular feeding with the bottle, feeding will show the pattern also. Like when they come to breast, often one side will be more painful than the other, often because that's where you can see the fascial problem is making the baby, it hurts to be on that side, and then they'll bite the nipple out of pain and discomfort in their body, not because there's anything the parent is doing. And so you want to watch all that. You want to assess. I assess with my hands and I hold the baby's body to see what is the fascia doing? What are the muscular patterns doing? And then I like to release the whole body using the pediatric Bowen, but I'll warm the body up first. Now I have these fabulous, really very warm pillows that were made by the Aileen LaPierre and the neuroaffective touch. And I'll just surround the baby with really beautiful warm pillows that are very soft. And Judy taught me that as well, using little pillows on places where you might find constraint. But so the parents will watch the babies just relax in my hands using the warmth. And I'll say to the parents, you can do this too. And I'll tell them how to make their own pillows if they don't have them. And then I'll do, a Bowen all the way through, up, around, and sometimes I'll go right into the psoas, down the legs to the big toe. I'll explain about the fascial lines in the body. And then I'll end with the cranial work. And everybody relaxes because the baby relaxes. Um, and sometimes the babies need a little bit more than one session. But I often can release a baby if there's nothing holding it like a posterior tongue high. I can release just a few sessions and teach the parents skills to be with their baby also.
Cool. Helen's asking about, can you recommend a Bowen therapy training for Europe and Ireland? Well, yeah, I mean, I teach a lot in Europe. I'm going to Bulgaria on Wednesday this week to teach out there, and I've just been in Ireland teaching as well. So there's if you want to contact me, and I've also written quite a lot about it. There's a couple of books I've done about the use of Bowen with babies as well. So,
Yeah, I find it hard to learn by reading. The best
yeah,
thing
you
to
can't
do,
learn by
the
you can't
best
learn
thing
by
to do is to go to class or even shadow. Come be with John in his clinic. I mean, I learned a lot from being with Judy. She would come to me and we would treat babies all day side by side. And that's a great thing to do. If you can come I don't know if you allow that, John, because that's
Yeah, but I think that the courses, the courses are the thing because it's, it's complicated. It's not, well, it's not that complicated, but it's a bit complicated. Yeah.
Yeah. Oh, I want to address Sonia's question about can someone please provide some direction on where to go for proper education on pre and perinatal psychology? I have listened to so many of the webinars from our birth journey and I'm soaking it up. Well, and you're a mental health practitioner in Nebraska. Where can you go to learn? Well, let's see. Well, there's at the Association for Prenatal and Perinatal Psychology and Health is a 12-module course that I created. It's been improved upon. I do think that I created it. I created that and ran it for 6 years. And that course describes a lot of the layers of experience. And then I think that what I would like to do, Sonia, if you want to email me, I want to hear where you are and what you can clinically do. I mean, what I teach and what I think needs to be taught is that we all have these layers of experience, and you will want to learn the hallmarks of those layers. They start preconception, so they're intergenerational, transgenerational things that show up in our bodies. But you can learn the hallmarks of each of these layers. And there are people that train in that, like that you can get a very thorough experience in learning, like the Castellino group. I think that they do a really good job of describing those layers. And there's clinical skills that you can learn there. And I offer a short training on the prevention and treatment of birth trauma, which is what my passion is, because so many people get hurt here and they're not cared for. So I do that. And there are courses in my online school that you can take, which is Prenatal and Perinatal Healing Online. And then there's lots of, like you said, John's work and Matthew Appleton's work and prenatal sciences. There's a lot of material. It's just, I would like to know your intention, like what is it that you feel like you're lacking? And I can definitely give you places where you can go learn.
That would be awesome. I would love that. Again, in the United States, we're really far behind, especially in the rural community that I live in. And so, yes, again, I've been a mental health practitioner for a really long time. When I was starting, the huge focus was behavioral health, CBT, and I just don't do a lot of that. I do more psychoanalytic trauma work with adults and kids. And as I've learned and grown, I'll have adults in my office, or I'll have teens in my office, and think if somebody could have got to them sooner, if somebody could have gotten to them sooner. And so I've kind of been going backwards. I'm trained in EMDR and with kids as in attachment. I'm trained in child parent psychotherapy,
Nice.
all those things. And so I like to have a holistic approach, again, limited in what resources are available in my community. And so wanting to know what I can do, what I can't do, who I should refer out, just those kind of things. So if we could connect, I would love that. That would be awesome.
Yeah. I put my email there.
Thank you.
Thank you. So, okay, we've got about 15 minutes left or so. Do you have any other case studies? I'm thinking particularly perhaps something that's been a bit challenging. Do you
For
have
me?
anything? Yeah. Sort of like perhaps not so straightforward. Do you have anything like that you could talk about? Because I know you've got a few there. You don't have to talk
Yeah.
about that, but if you got something.
Something that's been challenging for me. I wish you'd sent me that. I would have to really think that. But well, I have on my list here a baby that I treated named Verity.
Yeah.
And when she came, she was just like a week old, and she had this huge, you would call it a stork bite
Mm-hmm.
on her forehead, but I've learned that it's fascial constraint. Judy taught me it's fascia that creates these huge red swaths on people's heads. And
Mm-hmm.
Verity also had what Jonathan taught me is what we will call Magoo eyes. Magoo, very swollen eyes and very set back in her head.
Mm.
And she was angry. She just when you hear a baby cry, you know, they often have just ways of saying, I am so upset, or I'm miserable, or I'm hungry, or I'm bored, or I want to tell you all about this thing that happened. Like being born was so intense, and I want to tell you about it. But this baby was just angry. And this is a woman that lived in my neighborhood, and her cranium was shaped like the pelvis, like perfect outlet. And I said, was this baby low in your pelvis? And she said, yes, she was very low. She was a little baby. She wasn't a big baby. But I think she was low in the pelvis of the parent. And I think she got very constrained in her head. I don't really know exactly what made Verity angry, but she was pretty pissed off. And her crying was she cried a lot, so it was very hard. This parent had two other children, and there was it's desperate. Like, how can I soothe this baby? And again, this baby had the very challenging position of the fixed retroflexion. So she had this sort of twist in her body, and she had a lot of constraint in her head. And so I said, come every day for a week. And she lived in my neighborhood, so this was easy. for her to do. And I've never done that, John. You don't
Mm.
treat babies every day. You just don't. But this baby had so much pressure in her head that I just thought, okay, if I did a little bit of something every day for a week, it might relieve. And I gave the mother what Judy taught me to do, is to move the tissue little tiny bits at a time on her forehead with the little bit of the sign of the cross. So I told her to do that, and I did. I released like the Bowen, full body Bowen work, and a lot of cranial, because she's little. She was 4 weeks old. That they can't take a lot of the Bowen because they're so sensitive. And this baby in particular was so sensitive. So I did cranial work, and I did it in 20-minute, half-hour segments for a week. And then afterwards, she came as needed. But that baby's head totally changed. This thing on her forehead went away, and she became the happiest baby. Now, I live in that neighborhood. I used to live in that neighborhood, so I would see her at the pool. Verity is now 8. She is the sweetest child, and so happy to be alive. It's just not the same. I mean, that when I met her, she was really angry, and I made a documentary about my work. It's called "As the Twig is Bent, So Grows the Tree," and we started to make the documentary before the COVID. And then the COVID hit, so I never finished it. But I have the interviewed segments, and Alyssa was one of those babies. She wanted to give me testimony about the positive impact of baby body work and how it really saved this family from just dread and despair. But her story was more complicated too. She had tongue tie, and she had several revisions which grew back. So when you have revisions that grow back, you're like, well, the baby's body is just not moving enough. And then they have all these ideas around stretches or what have you, and her tongue really needed a lot more work. She saw a speech therapist and a oral myofascial therapist, and she had significant challenges in her body where she would W sit, and she had all these OT issues also. So I mean, I think it had to do with how she formed herself in utero. And her mother was right on it. I mean, this parent could probably teach how to be with babies
Mhm.
because she was so on it. But that was a very difficult case, but I don't know what the intuition I had to say, you come every day for a week. But I just needed to help this parent because she was losing her mind. And you have parents that they're losing their mind. You got to do something. Um, so that was a very difficult case that turned out really well.
Yeah, wonderful. And I often wonder in those kind of cases, Kate, what would happen if that baby had not been treated?
She would have stayed angry, and she would have,
Yeah.
the head grows. So that's another thing. Like, you have these fascial constraints in babies, and then they grow, and then they click, or they get more constrained, and their body adapts, and they walk around as children with their shoulders high and their craniums flat in different places. And I mean, I think my intention was to create body workers. I mean, there has to be somebody in every neighborhood that
Yeah.
knows how to do this. And there's only so many people that we can see. And luckily, I think I've seen more and more baby body workers, more and more people teaching it, writing books about it, bringing attention to it. So I do think that there's more and more people learning, at least over here. I don't know about over there, John.
Yeah, yeah. I mean, it's common for midwives to refer on to us cranial people because, but they're looking at it more from, oh, this baby had a difficult birth, they're crying a lot or whatever it is. So send them to someone like me, That's commonplace, I would say. But but I think, yeah, this question about the power of our work is really something. I mean, you know, if you look at a lot of people that are in power, you know, managers or politicians, and you can see their basically their early trauma playing out in the way that it does. I mean, there's that famous story about Henry VIII. You probably know that, you know, that he was brought up when he was a young, well, when he was a child and a young and a teenager. He was a very sociable, calm, kind man, you know, and then he had a jousting accident where he fell off a horse and hit his head. You know, and from that moment on, he became this aggressive, horrible character, which then had consequences literally for the whole world. I mean, certainly for the UK. You know, and you have to ask yourself, well, what would have happened if, you know, if osteopathy had been around then, or Bowen had been around, you know, I mean, literally, you know, it would change the world. So these
I
things,
agree.
it's so powerful, so powerful.
Oh,
There's a question here from Lucy about cranial. Kate, do you have any wisdom for midwives who are trained in cranial work and are still working in midwifery?
well, yeah. Well, I would like to know, Lucy, what would you like for yourself? I mean, are you getting tired of being a midwife and want other things, or
Ultimately, from what I'm seeing, ultimately I'd like to treat babies, but at the moment I'm full-time midwifery, and I'm doing things with mothers like helping release placentas, but I'd like to do things with the babies that, I mean, it has to be short term, so it's like prioritizing what a midwife can do that's trained in cranial work, you know, like in the immediate.
so what I'm hearing is that you want something more than midwifery, like you're getting
Well,
tired.
ultimately, when I retire, I hope to treat the babies, but at the moment, I'm trying to prevent the trauma. But
Mhm.
I've still got cranial skills that I could use in the immediate aftermath.
Yeah, that's great. I mean, what a great combination. And preventing birth trauma is also a thing. I mean, I teach that in my courses, but it's understanding the parent, understanding them and their body.
Mm,
You can help them with body work. I mean, I think body work's been horribly underrated. Helping parents create more space in their body, having them have good care, prenatal care, continuity of care, so there's a feeling of being held and safe. But things happen, things happen where babies can get stuck, and there can be compression and drag forces on the body, and then there you are. You catch the baby, you have to do a little this and a little that. You talk to the baby,
yeah, yeah,
and you try to say, yes, that happened.
yeah.
That's
I do that. I do
Yeah,
that.
good.
But is that the only thing that I can do?
The only thing.
Well, I mean, that's big. That's big. I really appreciate. I talked to those babies, and wow, that was hard. You know, you've done well, and but I just wonder if there's any sort of cranial um things that I could do.
More cranial training, you mean?
Well, no, well, yes, that as well. Isn't you can never have too much, but more in the instant. You know, the baby's been born, you've seen it's had this awful forceps delivery. You can empathize with the baby, but is there anything more hands-on or than just being empathetic?
Well, you do the cranial work. I mean, we realign them, you help them.
Mm,
You bring them into relationship with their
mm,
parent,
mhm,
the parent and the baby together.
mm.
Sometimes treat the parent, the baby gets better.
Yeah, yeah, that's a good
You
idea.
you hold the whole family.
Mhm,
If there's birth trauma, you integrate it.
mm.
Um, and so that's what I would recommend.
The parents. Yeah, yeah, that's a good shout.
Yeah.
Yeah,
Lucy,
thank you, Kate.
there's quite a few midwives who are also cranial practitioners in the UK. I'm just wondering, it might be quite nice to, I don't know, if we could have a sort of network of them and you
Oh,
could
that would be
exchange.
amazing.
I don't know how we would do that, but if
Amazing.
you wanted to email me,
Yeah, I
I
will,
could put you
John.
in
Thank you.
touch
That
with,
would be amazing.
yeah, I
Thank you.
could put you in touch with some other ones and share experiences. I think that could be really, really useful.
It could.
Yeah.
Thank you.
You're in the UK, right, Lucy?
Yeah.
Yeah. Yeah. Cool. Very good. Well, thank you, Kate. Any last things you want to
Yeah,
say?
I wanna tell another story, but it's going to go
Okay.
past the top of the hour. So
That's all right. No, that's fine.
is
That's
that
very
good?
good. Yeah.
All
Go ahead.
right.
Yeah.
Okay, so this story I often tell. I mean, I tell a lot of stories when I teach, and this is a little baby named Suzanne. She was 3 months old when she came, and her parent is from the Amish community. Now, the Amish community where I was living, there was a group to the south, about an hour and a half. They discovered me. They people that don't like medical doctors, they don't like cars or anything. They're the horse and buggy community. They would hire a van, and then like 5 families would come at once, and they'd bring their little kids. So there'd be like 20 people arriving at my office, and 5 parents with their babies and all their other children. So I would block off 2 hours, and the children would come in and out of my office and play in my yard while I worked with the babies one on one. And when I worked with Suzanne, she was like the last of the when they first came, she was the last of the 5, and I put her down on my table, and she looked at me like this, those big brown eyes above her arm. This is no, this is bracing. This is baby for no. And so I looked at her mom and I said, what happened? And she said, well, she had a dry birth, which I took to mean she released all her waters. And Suzanne was a big baby. So when she was born black and blue. It hurt a lot. So the first thing I did is I looked at Suzanne and I said, you didn't do anything wrong. Because when babies hurt, they think they did that. They think there's something they did. They deserve that or something. Like they get a little bit of there's something about that. This is something about me when it's not. A lot of things happen in birth that are very impersonal, and babies and parents take them very personally. So then I looked at her mother and I said, you didn't do anything wrong. And the whole room was filled with babies and children, and parents got very quiet. And so I looked back at Suzanne, and she had dropped her arms. She started to do this on the table. I said, oh, you want to show me? So I put my hands on her feet. And so this is how we help babies show their story. And helping a baby understand, like, I get it. Suzanne got it, that I got it. They're going to show you. They want to tell you about it. So she was wiggling up, and pushing against my hand. And so she pushed herself all the way across my table to the other side. And I asked her mom to come and sit on the stool on the other side. And I explained to her and to Suzanne, I'm going to pick you up now. I'm going to pick you up so you're upside down in my arms. So I held her like this. And I held her like this, and I said, you're going to be born into your parents' arms. And very gently, as she pushed with her feet down through my arms, and I couldn't see what was going on her face. So I said, Mom, what's happening? And she said, oh, she's smiling. I was like, thank goodness, right? And she pushed herself out of my arms and into the parent. And then she whipped herself around, looked at me, and did this, just with one of her arms. I said, oh, you used your arm to get out. And then she did this with her other arm. I said, oh, you used your other arm. You used your arms to get out. You're such a powerful person. You did that. And that empowered that baby and that parent. And the excitement on her face to tell her story at 3 months of age. She felt so met, and she lost her fear, And I cared for that family until the COVID happened, and they started to hire me to go down to their community, and I treated babies and all kinds of people that would come. But that baby, I mean, that was a life-changing moment to be held and seen in that way. And that would be what I would want for parents and babies.